We will move right now to the metastatic setting. And as you know, we have a lot of new options in this setting. Luis Pasares from the Hospital 12 de Octubre, he will try to identify which patient need to receive combination and which combination is better for each patient.
Okay, thank you, Elvis. Thank you very much. I think, may I have my slides? So thank you very much. And over the next 15 minutes, I'm going to try to cover those 4 aspects: frontline chemo, OSI, role of anti-eugenics, role of chemo, role of inhibition of MET, and some final conclusions. And I'm pretty sure that we will be plenty of debate after that. So no doubt that today the key, the cornerstone of the treatment of advanced EFR patients is third-generation TKIs, no doubt. The FLAURA trial set up the standard, clear impact on PFS, has a ratio 0.46, impact on OS, regardless. Most of the patients were offered treatment with OSI at the time of relapse. And particularly important, there is a clear prevention in relapsing in the CNS by the use of third-generation TKIs. This is a place with particular avidity of those tumor cells to have a recurrence or a progression, and that is an important aspect. We have seen, as mentioned by prior speakers, that first-generation TKI is also part of the standard treatment today, not only advanced, but in early stage, has been said here, for resected or locally advanced disease. And we have plenty of data now that other third-generation TKIs are maybe potential options in this setting as well. So I don't think those are, I would say, the very clear messages that we have today. The question is, can we improve the outcome of our patients? Are we able to prevent resistance to happen? I mean, Dr. Jan explained to us before potential ways to try to avoid resistance to happen here, particularly acquired resistance. The truth is that anti-eugenics has not been proven to really impact in the final outcome of these patients. It's not able to change the natural history. You see that you're increasing PFS, but I would say not final impact on OS, and we have now plenty of data, including with third-generation TKI, so I don't think today we can recommend the use of this. The second option had been the use of chemotherapy in this setting, and by adding chemotherapy to first-generation TKIs, we have seen some improving outcome, and that is being somehow reproduced by different groups. The question is, how much are we benefiting patients by using chemo plus third-generation TKI? And again, I think we have now quite mature data substantiating the increase in PFS. Look at the data, you're decreasing the rate of progression in 1 out of 3 patients as compared to the control arm, has a ratio around 0.62. And again, the impact is very clear in very relevant subset of patients. I'd like to maybe mention here the fact for patients with a particular propensity to relapse in the brain, those with CNS at baseline, has a ratio in that case 0.47. Those patients without brain metastasis do benefit. Maybe the magnitude of the benefit is not that high, at least in this analysis. And I also maybe to point out here a number of things. One is that the addition of chemo is impacting regardless the type of subtype of mutation, or at least this sub-analysis suggests similar hazard ratio for the 2 important classical mutation, exon 18 and 21. Second thing, very important, maybe those patients with PS0 are not benefiting as much. Is that related to the burden of disease, to the aggressiveness? We don't know, but maybe it's something we have to talk about. And as I mentioned, CNS is maybe one of the determinants, at least in this sub-analysis. And it's important to highlight that this is a sub-analysis that I'm not sure this is going to be reproduced all the time. Importantly, we have now some more maturity of the data. In fact, with longer follow-up and a maturity for survival of 41%, it looks like we are also impacting survival. One of the questions here is that impacting survival due to the fact that those patients receive chemotherapy? How many of those that is true? The good thing is that any other secondary endpoint seems to be here fulfilled. So overall, I would say we are impacting on clearly on PFS, particularly PFS on brain. We are likely to impact on survival for the whole population of patients, and the toxicity profile is not, I would say, very much impact. You just add in the toxicity associated to chemotherapy, as you see here. Oh, sorry. The toxicities associated with chemotherapy. Importantly, most of the patients do not need in the chemotherapy arm to actually withdraw the treatment with osimertinib. And if you look at PROs, maybe you're impacting somehow in more patients with loss of appetite and so on, but overall I would say there is not a clear impact in the quality of life by the use of chemotherapy, which I think is also relevant here. The third approach could be the use of a combination with MET inhibitors. We know this is a clear mechanism of resistance in this setting, and this is being extensively studied, particularly in the Mariposa trial with some other TKIs inhibiting specifically MET. Important to say that amivantamab is also inhibiting EGFR, so you're having here dual inhibition, complete vertical inhibition of the EGFR pathway plus MET. As you see here, the impact on disease progression is similar to that seen with chemo, has a ratio in that case 0.7. As we have mentioned before, the impact is similar regardless the patient is having an exon 18 or 21 mutation. And as you see here again, those with PS0 maybe do not benefit as much as we have seen in the prior study, and again, very similar data, regardless brain metastasis or not, or regardless the subtype of mutation. Again, all the secondary endpoints are also met here, and the survival seems to be there. The maturity is not quite there. At the present time, hazard ratio is in the range of 0.8, 0.78, and important, I would say, the use of this bispecific drug clearly modify the toxicity profile of the treatment. You have to remember here you're getting more classical side effects related to the EGFR inhibition, particularly rash, diarrhea, those related to MET inhibition, hyperalbuminemia, edema, particularly relevant in the cumulative setting, general side effects, and particularly relevant the infusion reaction, particularly in the first infusion, and also BTAs that require the use for at least 4 months of anticoagulation, because if not, you're getting that in some 40% of the cases. Importantly, now we are having some preventive measures. We are improving the way to deliver that drug, including having subcutaneous formulation, but still we are not yet there that we have abolished completely the toxicity profile. I just mentioned here less robust data we have with other MET inhibitors. I just put here the example of phase 2 with savolitinib in combination with osimertinib. I think it is clear that I would say there is a clear effectiveness with the strategy. I wouldn't say today we are ready for the use as today in the standard of care setting, this type of approaches. So at the time of discussing how to treat with a given patient in the clinic, should we use chemotherapy, osimertinib alone? We have been doing that for many years. We're pretty confident. Toxicity profile is pretty good. Are any patients requiring the use of combinations, FLAURA2 or Mariposa, and which of them? Looking at the data, there is clear impact in PFS, particularly on those patients with, sorry, I don't understand that, it's keeping going. It's quicker than me, sorry about that. And it is clear that for some patients, such as those with brain metastasis, where the risk of progression in the brain is particularly high, maybe one of the populations that we should consider the use of chemo or amivantamab. What would be the best? I think we have to discuss a bit on that. Remember always the combination is having toxicity. It is clear for chemo, but only for a few months, and maybe the side effects are not that strong. It is very clear for amivantamab. Remember the MET effect, infusion reaction, BTEs, and of course EGFR inhibition, complete inhibition, which is very clear. So at the time of deciding, I think we have to consider a number of factors, and this is what do we do. I mean, we have to consider the patient PS, particularly comorbidities. If the patient is having a poor PS, PS2 let's say, the PS is due to comorbidities, maybe you have to go with monotherapy. If the patient is having a bad PS because of the disease, we have data suggesting that for those patients, combinations may be better. For example, we have a sub-analysis of the FLAURA2 showing that the more metastases you have, the benefit is particularly there with the chemo combinations. So tumor burden, I think, to be considered. Co-mutations is something that is very important. We have seen that the effect is maybe true in patients with exon 18 and 21 without major differences. What we know is that the profile of the mechanism of resistance is not quite the same, depending on the treatment you're using. You see the number of patients with unknowns are actually increasing with the combinations as compared to the use of osimertinib alone. Maybe FLAURA and FLAURA2 regimes are not totally different in terms of the patterns of progression. You see here that by the using of amivantamab on top of OSI, you decrease in the resistance through MET amplification or through EGFR activation by any mechanism, and I think that's relevant. In terms of commutations, I don't think commutation in P53s are helping us to decide. Patients are benefiting the same with combinations, regardless the presence of not of P53 mutation at baseline. And the same is true when talking on ctDNA. Baseline ctDNA is a bad prognostic factor, but it's not predicting who is benefiting. And ctDNA response is just telling us who is doing well and who is not doing well. So far, I don't think we have data to substantiate our decisions based on that. There are trials trying to define the dynamic role of ctDNA. Could we start patients on OSI and depending on the responses to 2 to 3 courses, then adding on or not chemotherapy or amivantamab? So at the end of the day, still we have again toxicities and convenience, and that's maybe something very important. Ask to the patient would be still a very important part of what are we doing into the future. Remember that our decision is going to have an impact on the strategic treatment pathway of the patient. Depending on what we do here is going to depend on what we are doing next. For that, I think it's important to take into account when deciding the first-line treatment, what is going to be the best way you treat this patient in the future, and that is going to depend as well on the access to other treatment possibilities in your treating media. So I'd just like to finalize by saying we have at least 3 opportunities here of treatment. Still many patients are well served with third-generation TKIs alone, and always consider all the factors that may be involved here, from patients' factors to disease or tumor-related factors, and side effects, convenience, and importantly, the access to the patient and the health system to the drugs. So that is my final slide. Thank you very much indeed.